So I guess we'll get started then. Welcome everybody to this UK Kidney Association webinar. This one of the series is on chronic kidney disease associated pruritus, and it's been jointly organised by two subgroups of the Kidney Supportive Care Specialist Interest Group. It's a bit of a mouthful, so there's some of us from the research and data subgroup and others from the symptoms subgroup. And we've got two speakers today who are going to present to us. So first up, we're going to have Dr. Jacqueline Nevols, who's going to talk to us about the treatment of chronic kidney disease pruritus and the evidence base. And next we've got Dr. Brendan Smyth, who's going to talk to us about how we treat itch, a 3-country survey of CKD-associated pruritus treatment practice. We can start with Jackie. So Jackie's a consultant nephrologist who works at the hospital in Portsmouth. She's got an interest in kidney supportive care, mental health, skin and symptoms, and has set up the service there. And Jackie, I'd like to invite you to give your talk. And then we're going to go into Brendan's talk straight away and questions at the end of the seminar. Thanks for your attention. I'll stop sharing.
Thank you very much. Bear with me. I'll just share my screen. And Brendan, if you give me a quick thumbs up so I know that it's working. Wonderful, thank you. So afternoon, everyone. Thanks very much for the kind introduction and welcome to the session on CKD-associated pruritus, the evidence base. I have no conflicts of interest to declare. So here's a quick overview of my talk this afternoon. I'll briefly talk about the prevalence and the importance of this condition. And I thought it would be helpful to talk through the pathophysiology, or at least the theories behind it, just to help illustrate the bewildering array of treatments that are potentially available, and then move on to the evidence behind each of them. And hopefully this will lead us on to a proposed management guideline which you can use in the clinic. So let's start then with a definition of CKD-associated pruritus. We all know it's an unpleasant symptom. It provokes the desire to scratch in renal patients, but it's important to rule out any active skin lesion, even eczema or even scabies, that requires separate treatment. And we all know it's exceedingly common. But actually, the prevalence of CKD-associated pruritus seems to be decreasing over time, as evidence from the DOP study, Dialysis Outcomes and Practice study, and over the 5 phases, the prevalence seems to be decreasing. The reasons for this are perhaps unclear, but probably something to do with different dialysis techniques over the last 20 years or so. And this is a chart here that shows the prevalence of CKDaP divided into countries. And you can see, unfortunately, the UK seems to be performing worse. So there's plenty of work to do in this country, which is quite surprising. Is it a big deal? Well, actually, yes, I think it is. CKD-associated pruritus is associated as an independent risk factor for depression, a reduction in health-related quality of life, and also poorer sleep, and even a higher mortality risk. And this is probably because CKD-associated pruritus isn't a disease in itself, but it just reflects what's going on in the rest of the body, perhaps even an inflammatory process, which we'll discuss shortly. CKD-associated pruritus has been identified as a really important area for research by patients. And traditionally, patients don't actually complain about it very often in the clinic, and doctors don't ask about it very much. And indeed, data from the latest DOPS phase 5, shows that medical directors often underestimate the severity of their patients' symptoms. So what is itch? Well, the sensation of itch is mostly triggered by an action of an ever-growing list of a variety of compounds on receptors on C nerve fibers, which then transmit the impulse to the posterior spinal thalamic tract, to the thalamus and sensory cortex in the brain. And now there is also a psychological element to itch, and I apologise in advance, but several of you will be scratching by the end of my talk today. The incidence of itch increases with a variety of risk factors, which can be thought about in the clinic, and it increases as your eGFR drops. It's also more common in the elderly and in those with increasing comorbidities. It seems to be less common in peritoneal dialysis patients, and I think this is probably because of increased clearance of uremic toxins with their increased urine output. And here is a schematic which I borrowed with the very kind permission of Brendan, my co-speaker today, and it just illustrates the various numbers of stimuli that are involved in the generation of the itch sensation. You don't need to remember all of these, but I just wanted to use it to illustrate there are a number of therapeutic targets. So moving on now to talk about the potential theories about the pathophysiology, and you can see there are quite a number and they probably all interact with each other. And for each theory, I'll just give a list of a number of treatments that have been tried in the literature to date. So firstly, inflammation. We know from the DOPS and other studies that markers of inflammation, such as a low serum albumin, correlate with itch. And we also know that CKD patients have increased numbers of inflammatory cells, such as mast cells, in their skin. Zinc I'm getting increasingly interested in, and zinc is commonly deficient in CKD patients. It's a mast cell stabilizer, and zinc deficiency promotes degranulation. And there's a huge list of other inflammatory proteins listed here and cytokines that are potentially involved in itch. CKD patients have a greater T helper 1 cell response, which is pro-inflammatory. This has led to a number of trials in the last 10-20 years or so involving things like mast cell stabilizers, chromalin, sodium, zinc, and nicotinamide as examples, and we'll talk about antihistamines in the next slide. Montelukast and the others listed here are immunomodulatory, for example, turmeric, which is getting more common in some literature, and polyunsaturated fatty acids, which block the conversion to arachidonic acid, which is part of the pro-inflammatory pathway. So lots of options. Here's just a few short statements about antihistamines. Now, when I started training, antihistamines were recommended for treatment for uremic pruritus, and it was all caused by high phosphate, and we'll see that that is different now. And although some basic science does point to histamine being involved in the pathogenesis, unfortunately, the clinical trials that we do have show that they show no benefit in treating this condition, and they're certainly no better than emollients on their own. Some guidelines do consider the use of antihistamines, but purely for their sedative effect, particularly things like hydroxyzine, which is more sedating than other antihistamines. So despite what we now know, it's interesting to note that even in the latest phase of the DOPS study, antihistamines are the most commonly prescribed drug, and I'm looking forward to hearing Brendan's data about this later. The next theory is uremic toxins. This theory came about from the observation that lower efficiency dialysis itch is more common in these patients. And there's interest these days about two specific uremic toxins called indoxyl sulfate and p-cresyl sulfate. These compounds have been shown to upregulate PAR2 receptor expression, which is involved in the itch pathway, and they are independent of histamine. These compounds are not removed by conventional dialysis. But of course, the most poignant indicator that uremic toxins are involved are the fact that the vast majority of transplant patients are cured of their itching once transplanted. So thinking about this theory, lots of people have tried different modalities of dialysis and even other methods of removing uremic toxins from the body, for example, via the gut with activated charcoal. But unfortunately, the evidence does not point to proven benefit for any of these methods. The next theory I'll briefly talk about is CKD mineral bone disorder. Early studies did show increased levels of calcium in the skin, and there has been some association noted in some reviews with phosphate and PTH levels. But this is not borne out in later studies. The latest phase of the DOPS database shows no association with phosphate levels. There are no controlled studies of CKD-MBD treatments for treating pruritus. There is one case series of 37 patients who underwent parathyroidectomy, and it was noted that their itch scores improved postoperatively. This led to some excitement that PTH was the cause of itching, but this has not shown the case in subsequent trials. So let's move on to the more interesting theories. Firstly, looking at the neuronal pathways. This involves gamma-aminobutyric acid, or GABA, and serotonin, otherwise known as 5-HT. In dialysis patients, we also know that peripheral neuropathy is common, and compounds called neurotrophins, for example, brain-derived neurotrophic factor and neurotrophin-4 may be involved and may be potential therapeutic targets for the future. Even BMP may be involved. So what can we try? Capsaicin is a substance that depletes substance P and has been tried in the management of itch, but I'm not convinced by the data so far. We also know that anything that cools the skin may be helpful. And actually, we all know that if you've injured your knee, put an ice pack on it, and pain is transmitted by C fibers the same way that itch is mediated. So cooling has been looked at by various mechanisms. And looking at medications that have been tried include the antidepressants and the gabapentinoids, which we'll talk more about later. And the final theory is to do with endogenous opioids. In chronic kidney disease, we know that there's an imbalance with opioid receptors between the propruritic mu opioid receptor and the anti-pruritic kappa opioid receptor. People have looked at trials of opioid receptor antagonists or agonists as follows. The mu antagonists, such as naloxone or naltrexone, have been studied, but unfortunately do not improve itch and are more trouble than they're worth. There was quite a sizable trial looking at nalbuphine, which is a combined mu antagonist and kappa agonist, but it's only available in Japan, but may have some effectiveness. The excitement comes with the bottom line here, the kappa agonists. Now, furofene's been studied for a while, but we now have diphenhydramine available, and both of these have been shown to be antipruritic. And usefully, they don't have any mu effects, so they're not potential drugs of abuse. So let's move on now to talk about the actual evidence base about the potential treatments that I've recommended here or mentioned. If you put the management of itching into PubMed, you come up with a huge array of articles. And it's important to note that even if you narrow down your search to CKD-associated pruritus, there are more review articles than there are clinical trials. The Cochrane review looked at 58 randomized controlled trials. This was back in 2020, so it doesn't include diphenhydramine, with just over 3,000 patients in total. This may sound quite a lot, but when you think about some standard cardiology trials, they often have 4,000 or 5,000 patients per trial, so it's not actually that many patients. This review looked at a large number of different interventions with a diverse set of comparators, and studies were often small and certainly not all randomized double-blind controlled trials. So it's difficult to draw firm conclusions. On the plus side, though, there are very few severe adverse events reported, except perhaps for the kappa agonists. Most trials were conducted in hemodialysis patients, but I do think it's reasonable to extrapolate the data into CKD, transplant, and PD patients. This review wasn't able to draw meaningful conclusions looking at quality of life issues, and more data is required. And I'd just like to talk about the visual analog scale, which will help us understand the data as for the rest of the talk. It's the most common tool used to measure itch scores in the literature. So it's a well-validated tool used in most clinical trials. The patient is asked to put a mark on a 10-centimeter line to grade the severity of their itching. So at the start, their itching may be towards this end of the line, say 8 centimeters. And after a few weeks treatment, the itch hopefully will be at this end of the line, perhaps 2 centimeters along the line. So the difference is 6 centimeters. A 2-centimeter difference is said to be clinically meaningful. So for the rest of the talk, I'll present each treatment and note the number of studies in a systematic review, the number of participants involved in the trials, and the main quantitative data on the mean reduction in VAS score, along with confidence intervals. There are, of course, other scores used in the literature, such as a duo score, but I'd like to keep things simple for the remainder of today's talk. Thinking about review articles, these two I feel are the easiest to read and offer a really good comprehensive review of the literature for CKD-associated pruritus, and I highly recommend them. The top left one by our co-speaker today, Brendan. For those unfamiliar with how to grade evidence, this is a useful pyramid that tells you about the hierarchy of evidence in the literature, with the top systematic reviews and randomized controlled trials the best, and at the bottom, the case reports and expert opinion, upon which a lot of the review literature is actually based. The highest quality data we have is for these 3 drugs, and I'll talk you through the top line just to familiarize us with how the data is presented this afternoon. So this is from a systematic review of 5 studies of gabapentin, which included almost 300 patients, showing a mean reduction in VAS score of 4.95 centimeters with tight confidence intervals between 4.5 and 5.5 centimeters. Thus, the evidence for gabapentin shows a large and homogeneous magnitude of effect, which is actually unlikely to be altered by further study, so quite convincing. The effect of nalfurafine, a kappa agonist, is perhaps more modest. Ondansetron, which is a serotonin antagonist, has been shown to be ineffective, and you can notice how the confidence intervals cross 0. Further agents of interest are montelukast, turmeric, and zinc sulfate, noting that turmeric study used a different score called a duo score, so it shouldn't be taken as more effective than gabapentin, because I don't think it is. My view on why gabapentin seems to have the greatest effect is that it acts on the final common pathway of the itch perception, on the neuronal pathway, and all of the others act on a single compound or inflammatory mediator or receptor. I should add that the Cochrane review also talks about capsaicin possibly being useful. This is the substance P inhibitor, but I'm not convinced by the data, and it causes significant side effects. So what is gabapentin then? It's not actually an analogue of GABA, as the name suggests. It's a compound that inhibits calcitonin gene-related peptide release and consequently limits nerve conduction. And although gabapentin is one of the most well-studied medications in CKD-associated pruritus, there was significant heterogeneity between a number of studies with different trial design, some trials only having twice-a-week dialysis, and also dropout rates. 5 additional studies compared gabapentin to antihistamines, and gabapentin came out on top, but again, no standard trial design. In terms of dosing, different doses have been used in trials, but Cochrane recommend 100 milligrams of gabapentin a day, or the alternative pregabalin at 25 milligrams a day, which is sometimes better tolerated. I actually start at half that, or even alternate day dosing, just to check for tolerance. Both drugs are dialyzed, so it's important they're given after dialysis sessions. One study looked at the comparison between the two, and there's no difference in efficacy. In the trials, side effects were noted to be mild and infrequent, but I would add a note of caution here, because most of the participants in the trials were young. Interestingly, gabapentin is now the 10th most prescribed drug in the US due to the opioid epidemic and the need to find different painkillers, and concern has been raised in the US, as noted by this trial here. So concern's been raised that gabapentin and pregabalin cause a dose-dependent increased risk of confusion, falls, and fractures in hemodialysis patients. So we do need to be cautious about prescribing them and not dish them out to every itchy patient. Now let's look at the kappa agonists. Now, furafine, as we've seen, has a modest benefit on pruritus, but it's only available in Japan and Korea, and side effects seem to be quite common. Difelikefalin is a newer kappa agonist, which is now specifically licensed for the treatment of CKD-associated pruritus. It's given intravenously after dialysis, so at the moment is only suitable for HD patients, but oral preparations are trials of which are underway. The first trial showed an improvement in itch scores after 8 weeks of treatment compared to placebo, and a phase 3 trial showed similar results, but the significant placebo effect should be noted here. Side effects include diarrhea, dizziness, and vomiting, but did tend to be mild. This data did show some significant improvements in sleep, mood, and social functioning in the difelikefalin arm, which are important for patients, of course, so it's certainly a promising treatment. I've started to prescribe it in Portsmouth in just 1 or 2 patients. It's early days to let know where I'm confident using it, but it's good to have it available. The last class of drugs I'd like to talk about are the antidepressants, which aren't the first thing that come to mind when you have someone with itching, but actually these drugs are widely used by dermatologists and palliative care physicians to help manage itching, probably due to their easy tolerance and good safety profile. But to date, there are no adequately powered randomized controlled trials looking at these drugs in CKD patients. There are some promising data from some small studies that I've listed here, more information on mirtazapine on the next slide. And perhaps the most interesting ones are sertraline and mirtazapine, in my opinion. I think antidepressants could be a useful additional option for refractory cases, and they're certainly recommended in other pruritic conditions in European guidelines. So one of my favourite ones to consider is actually mirtazapine. It's frequently used in palliative care settings for malignant disease and also cholestatic jaundice. And there's clinical trial evidence in a randomized controlled trial of its effectiveness in post-operative itching due to opiates. What is it? Well, it's a combined noradrenaline and serotonin receptor antagonist, as well as having affinity for histamine receptors, so a wide base of potential targets. But the only evidence we have in renal patients is from a relatively recent open label trial undertaken in Iran, where mirtazapine was compared to gabapentin. And actually, mirtazapine came out more popular with patients and more effective. But we certainly need a placebo-controlled randomized controlled trial. Watch this space. So we've talked about medication. What can be done about dialysis? There are some techniques to improve the clearance of uremic toxins, such as high flux or high permeability dialysis. Although studies do look promising, it's difficult to be convinced by this data due to the heterogeneity of the trials, and it's graded as low certainty evidence. Other techniques have been tried, such as hemoperfusion, which is similar to immunoabsorption, which you may have heard of, and adding in HDF or high flux dialysis as well. My bottom line from looking at this is that optimizing dialysis may have some benefit, and there are certainly other reasons to optimize dialysis, not just itching. So what else can we do when we consider the systematic reviews and optimizing dialysis? One's tempted perhaps to just prescribe some gabapentin or difelikefalin and then move on. But given the potential pitfalls of systemic therapies, it's important to consider conservative measures as well. There is no trial evidence for these recommendations in CKD patients. This just comes from standard advice from talking to dermatologists as well as expert opinion. I advise my patients to avoid washing too frequently and do what they can to avoid scratching, as this really makes itching worse. Anything that might irritate the skin should be avoided, particularly wool fabrics, and even things that mum used to do, like put a handful of porridge oats in the bath when you had chickenpox, and that's been shown to be helpful in other skin diseases. What about topical therapies? We know that in other conditions such as eczema, that topical therapies are better than systemic agents at reducing itching, and they're certainly preferable, I think, in the elderly who are already subject to significant polypharmacy. We do need to think about whether or not a patient is able to even apply topical therapy, so have a think about that in the clinic. Although it's tempting to consider topical steroids, these are not recommended in CKD-associated pruritus in the absence of any other skin disease. So what are emollients? What do they do? Well, they strengthen the skin barrier and prevent transepidermal water loss to moisturize the skin. Dry skin or xerosis is extremely common in chronic kidney disease patients, as we know. And although dry skin correlates with itch, it doesn't actually cause it itself. Emollients are readily available and cheap, and their prescription can even be nurse-led, but actually there's very little evidence that these are effective in CKD-associated pruritus. Many creams have been looked at, but most studies are quite small, uncontrolled, with various methodological flaws. The two most widely quoted studies in the literature are just case series, but they do show some promise. If itching continues, then consider adding a topical anaesthetic, which have been looked at. Pramoxine is a local anaesthetic, which has showed a greater reduction in itch intensity compared to placebo, but this trial was not adequately powered and has not been repeated to date. Capsaicin we've talked a little about already, but because it causes significant burning on application and you're only able to use small amounts, I would judge it as impractical. Topical cannabinoids have been used in an uncontrolled trial, but my main interest lies with loramacrogol, which is another local anaesthetic, and this is readily available over the counter in creams such as Balneum Plus and E45 itch cream, and they're widely used by dermatologists for other skin conditions, for example, eczema, atopic dermatitis. There is a large amount of data from post-marketing surveys and observational cohort studies showing good symptom control. So if you'll permit me just 30 seconds to talk about my own RCT that I performed a couple of years ago now, which compared VAS scores before and after 4 weeks of twice daily treatment with either Balneum Plus or plain E45 as a control cream. In the plot there, we can see E45 in blue and Balneum Plus in red, and baseline VAS scores on the left and 4-week VAS scores on the right. And you can see that this was a negative study. There was no difference between the two creams. I can't say, and I'm not allowed to say from my study, that emollients improved itching per se, as there was no group in the trial that did not apply any cream at all, as I didn't feel that was ethical. But I concluded from my study that as long as someone is interested in your symptoms and a cream is applied regularly, it perhaps doesn't matter which one you use. And to finish, I ought to just mention a few adjuvant therapies that have been tested in the literature. For interested and selected patients, they may be of use. These are things like acupuncture and aromatherapy, which are widely utilised in the Far East and in the Southeast Asian countries. I would also like to make a quick note about mental health. There are 10 randomized controlled trials in atopic dermatitis patients for psychosocial programs, and they are recommended in the Cochrane Review for treatment of eczema, which basically involve education around the itch scratch cycle. And this is something I think that needs further research in renal populations. Thinking about UVB therapy, there is low certainty evidence of the efficacy of UV light, and it carries a significant treatment burden when you think patients are at dialysis 3 times a week, and then they've got to go to have their UVA or UVB treatment 3 times a week as well. It should only be really considered as a last resort in young transplantable patients due to a skin cancer risk, but this risk has been downplayed with recent studies. I have used it in a handful of rather desperate uremic pruritus patients, and it did seem to be useful. So after that tour of the increasingly complex literature, here is a proposed guideline for managing CKD-associated pruritus. Assuming that other dermatological conditions have been ruled out, I'd start by educating the patient about washing, clothing, and avoidance of scratching. I would then advise to optimize their dialysis if appropriate, and then add a moisturizer. If this isn't enough, you can add a topical anesthetic. And if they're still itchy, after a careful discussion about the risks, then add gabapentin or pregabalin. And then dialysis patients, you can use now difelikefalin. Now, I purposely left the randomly assigned PowerPoint icon for an ice cream there. That was in the slide designer function, but this drug really is the icing on the cake. And in refractory cases, you have a number of options here you could consider: mirtazapine, UV light, montelukast, zinc, and even turmeric. Let me conclude by saying it's important to ask your patients about their symptoms and follow up on a treatment plan so you can try something else if plan A doesn't work. There are a large number of potential treatments available, with more targeted therapies being developed. And as ever, of course, in renal medicine, there are more opportunities for further study. And I'm quite interested in looking at a randomized controlled trial with mirtazapine versus a placebo. So if anyone's interested in collaborating with me on that, please do get in touch. Thanks very much for your attention. Here are my references, and I'm happy for the slides to be shared. Thanks very much.
Jackie, thank you so much for such a detailed and well-researched presentation. I'll get you to stop sharing your slides. Thank you so much. Look, some questions already coming through in the Q&A. Thank you for that, everybody. You should be able to continue to ask your questions during Brendan Smith's talk, which is coming up right now. Some clues there from Jackie's presentation: that long list of potential agents available to us, the mixed evidence. It's going to be really interesting now to hear from Brendan, who is a nephrologist from Sydney, Australia, who has got an interest in developing the evidence to help with symptom management for our complicated patient population, and putting that evidence into practice. And he's going to present to us on chronic kidney disease-associated pruritus practice patterns across 3 countries. So take it away, Brendan. Thanks very much.
Thanks so much, Barney, and thank you for having me. And Jackie, that was a fantastic talk. Very interested to see your perspectives. And what we'll talk about today is a survey that I worked on with Barney and his colleagues at Bristol, where let me just make sure that's working. There we go. So some disclosures briefly. I have consulted for CSL Vifor. So the background is, as you've seen, there are many treatments available for CKD-associated pruritus. Lots of randomized trials, more reviews than there are trials. And many of those trials are actually relatively low quality. They're either small in size or single center. And so we don't have a lot of aggregate information that can provide us with confidence about relative treatment sizes. And I'd also note that there's not a lot of comparative data as well. So we may know that gabapentin is effective or seems effective, have some data about sertraline, for instance, but there's not a lot of head-to-head studies. So it's often hard to know where to start. As a result of this, there's no standard of care. There's no major society guidelines. You know, the KDIGO group has not got together to produce a pruritus guideline, for instance. We were actually interested then in what are people actually doing? What are people using? And how does that differ between sites and countries? So with colleagues in New Zealand and the UK, we set up a survey. And the survey was designed to ask about management of symptoms in people with kidney failure, but as well as the practice patterns associated with kidney supportive care. Now, that information will be presented elsewhere. We identified dialysis units in Australia, the United Kingdom, and Aotearoa in New Zealand, and conducted the survey between April and December last year. Each unit could provide us with one response, and that we asked that response reflect what they thought was the usual practice at their unit. Specifically for CKD-associated pruritus, we asked which of the following, we asked about a group of systemic and topical treatments, and we asked for each of the treatments that we listed, and there were 20 systemic treatments and 8 topical treatments that we asked about. We asked respondents to choose whether they used that agent as a first line, second line, in refractory cases, rarely or never used. And there were some caveats we put in as well, so that we asked people to assume that they had already tried an emollient and so some basic skincare before moving on to these additional treatments. Okay, so we contacted 171 units, 89 in Australia, 70 the UK, and 12 in New Zealand, and had a decent response rate of 67%, giving us over 100 units in the 3 countries. Of those, 2/3 had a kidney supportive care service and 1/3 did not. The sort of people who were responding were, of course, mostly nephrologists, but we also had a lot of responses from nurses, particularly people who were kidney supportive care nursing staff as well. The units themselves were sort of comparable what you would expect for each country. We did quite well at managing to get a hold of all units or contacting all units in most countries and got responses from a majority of units in most countries. And in terms of unit size, the units in the UK were larger than those in Australia and New Zealand. But the core of this presentation is just to go through the results and show you guys what is actually happening on the ground. So as you may expect, from Jackie's talk, gabapentin and pregabalin were the leading first-line treatments, and that's 35 and almost 25% of responses indicating that that was a first-line treatment for them. And note that respondents could list more than one first-line treatment. Evening primrose oil closely followed pregabalin. And then you have a number of antihistamines, promethazine, hydroxyzine, and diphenhydramine, and a smattering of other agents, including turmeric and sertraline, as we've heard of. There was a wider degree of second-line treatments that people were using. And you'll note that pregabalin and gabapentin head this list as well, which tells us that there are certainly differences between units, with some practitioners starting gabapentin and pregabalin as first line, and others using it in reserve as a second line treatment. You can see a wider range of things such as difelikefalin, zinc, montelukast, nicotinamide, and even thalidomide, for which there is some small low quality evidence to suggest efficacy. I'd note that given this survey was last year, the use of difelikefalin may be increasing. Again, for refractory cases, we're seeing a similarly wide range of treatments, with some people even using cromolyn or nalfurafine. Turmeric creeps in there. But you still see the same mix of antidepressants like sertraline, antihistamines, gabapentin, evening primrose oil, and pregabalin as last line treatments. In terms of topical treatments, Menthol was the most popular topical treatment, followed by capsaicin. Interestingly, there's still some use of hydrocortisone, as well as agents such as a topical gamma-linoleic acid and lignocaine. Second-line topical treatments include hydrocortisone, which I found a little striking, given that there is no evidence to support hydrocortisone's use for CKD-associated pruritus. But I suppose this partly reflects that if people are becoming desperate to try something or find something that works, it's easy to reach for the hydrocortisone cream. UVB treatment does creep in there as an available second-line agent. And even things like topical pramoxine are used in some circumstances. So you can see the wide range of topical treatments that people are using, similar to systemic treatments. In terms of responses for other treatments, there were some additional antihistamines that we had not actually asked about that people are using, such as loratadine, cetirizine, or chlorpheniramine, and some people just responded with antihistamine. There was a little bit of mirtazapine use, with 5 respondents indicating that they are using that. And again, a mix of topical treatments that included pintosol, coal tar, even someone said they used peanut oil, which I suppose may be an emollient. The topical Gaviscon I found interesting and have not been able to find a rationale for that one. There were also some interesting differences between countries in the use of various agents. And what I've done here is I've categorized the responses as routine use, meaning first or second line treatment, and then rarely or never used, meaning refractory cases, rarely used or never used. If we look at doxepin, there was 10% of people in Australia use that either first or second line, versus essentially no use of that in New Zealand or the United Kingdom. Similarly, evening primrose oil is a popular agent in Australia, less so in New Zealand, and it seems to be rarely used in the UK. The pattern is reversed for hydroxyzine, which is reasonably popular in the United Kingdom, but rarely used in the other 2 countries. Promethazine is the other way around, and this may just reflect the availability of different antihistamines in the different countries. I don't think hydroxyzine is actually available in Australia, and I'm not sure about promethazine availability, but it's quite easy to get in Australia, and hence there are some people still using it. There are also a few differences in use of topical menthol and the gabapentinoids, pregabalin and gabapentin combined here, in units with renal supportive care service, kidney supportive care service, and units without kidney supportive care. So you can see on the left here, there's some indication that gabapentinoids are more commonly used at units where there is a kidney supportive care service, where they're a common first or second line agent, and very few kidney supportive care service units said they never used gabapentinoids. With menthol, it's the other way around. There's more, perhaps more awareness about topical menthol and more interest in using that at units that do have a kidney supportive care service. I also found it interesting to note that while there's there's a reasonable amount of evidence for gabapentinoid use, there are still quite a number of units that don't use it at all. So our survey obviously may suffer from responder bias in that we are likely to be getting people who may be more engaged in providing kidney supportive care. And for some of these items, there are a small number of responders. But I think we can draw quite confident conclusions that there's a wide variety of treatments that are in use for chronic kidney disease-associated pruritus. And there's a lot of variability between sites. Gabapentin being a good example, where some sites are using that as first or second line and some not using it at all. There's some clear differences between countries and between sites that have a kidney supportive care unit. I'm not sure how difelikefalin may change practice as its availability increases, but that's something to consider going forward. I think we definitely need some more evidence to guide treatment and help the development of proper evidence-based guidelines. I think some of the gaps in the availability of comparative information, and I think as Jackie talked about, we tend to cycle through treatments. You try something, then if that doesn't work, try something else. It would be useful to have some studies that actually explore, after a trial of, say, gabapentin, for those who don't respond to that, what is then the next best option? Our study proposal that we've put in for a funding application for earlier this year. So if we are lucky enough to get some funding, we should hope to start this study late next year, would be aiming to try and answer some of these questions by providing comparative information, comparing an antihistamine, an antidepressant, a GABA agonist, and gabapentin, all to placebo, and providing rescue randomization at 6 weeks in. If patients don't tolerate one agent, they have the opportunity to be randomized to something else. And I think some more flexible designs such as this would be useful to help elucidate better evidence for treating chronic kidney disease-associated pruritus in the future. So thank you very much to the working group that helped develop and manage this survey at the University of Bristol, Sarah and Charlotte and Barney, and our colleagues in Australia and New Zealand. That's it. Thanks very much.
Brendan, thank you so much again for an incredibly detailed and excellent presentation. We've spoken about it many times, but what we see there is variation, 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 isn't it? And that tells us a lot about the evidence available and how people interpret it. So I suppose that now leaves us to ask some questions of the presenters. And at this point, I'm going to step down and pass over to Catherine, who's from the symptoms side of the supportive care specialist interest group, and let her host questions to the presenters. Don't forget, you've got the questions and answers and the chat if anyone wants to ask questions yet. Over to you, Catherine.
Thank you both for fantastic presentations. They were really interesting and informative. Brendan, can I start with a question? So your study proposal at the end, is that for a study just in Australia, or is that going to plan to roll out to the 3 countries that you did the survey in?
So assuming we get funding, we actually do want to roll it out to the UK, maybe New Zealand, but Canada was one of our other collaborators is from there.
Okay, just thinking of the availability of the nalvarine. I don't think that's licensed.
Look, you can, although I think if you purchase it, it can be, we could use it in the trial. And that's part of the thing is, if we generate some evidence, then that might prompt people to, if it's useful, to set up supply outside of East Asia.
Fantastic. Fingers crossed. So Jackie, we've talked about difelikefalin is kind of the new big thing for dialysis patients, but is there any kind of trials or anything up and coming for those patients who aren't on dialysis?
Yes, there are. There is an oral preparation in development, and there's a few trials underway looking at that. So that would make it more equitable. That was my main problem with difelikefalin when it came out, is that it was only suitable as an intravenous preparation, so it could only be used in HD patients. But watch this space. It should be available in a tablet form, hopefully, in the next few years.
Great. Right. So some of the questions from the chat. So I think, Brendan, you've kind of partially answered some of these. So somebody's asked, what are Germany doing to make the levels of itch so much lower than the UK?
Oh, I can put an answer to that. Part of my trial looking at Balneum Plus cream, that's actually manufactured in Germany, and they seem very, very interested in patient symptom control there. And there's most of the data looking at observational data with once these drugs are on the supermarket shelves, what they actually do. They're really interested in following up their products that they investigate in Germany. So I think it's more people being interested in it. I hope that's not the case that people aren't interested in it in the UK, because I certainly am, but lots of work to be done.
David, do you want to come in?
Yeah, so I was just going to ask similar question. UK is doing terribly according to your data, Jackie, but yet when we look at Brendan's data, for the people who responded, we're using as almost first or second line, some of the things which have potentially the best evidence. So really, why is it that we're doing so badly, do you think? Do you think it's just that we, my personal feeling, I don't know if you agree with this, is that we're not very good at having sort of national guidelines, which we're hoping to change, on symptom control. And I think people don't ask a lot about symptoms, and therefore they're not managed. People are scared because they don't know what to give. And maybe that's why we're doing so badly. But I would appreciate both of your opinions on why you think we're doing so badly.
No, I think you're right, David. It's really important to ask patients about their symptoms. I was definitely taught as a nephrologist to look at EPO dose and phosphate binder dosage, and that was about it. I wasn't taught to ask patients how they feel, but I certainly do now. But I think one of the issues is in the UK, we certainly take on quite an elderly and comorbid group of patients for renal replacement therapy. So one thought I did have, this is not proven in a study, is that the cohort of patients we dialyse in the UK have lots of these symptoms going on, but we perhaps wouldn't have picked it up if they were managed conservatively out in the community with general practitioners. That's what I think. Not necessarily that we're bad at treating it, I hope.
Yeah, the UK is not alone in not having guidelines for managing chronic kidney disease-associated pruritus. I mean, nobody has really. I mean, there's a lot of reviews that have suggested proposals, but it's a difficult area, actually. Despite the wealth of trials, they're all small and don't provide a lot of confidence. So, I don't think you guys need to be too down on yourselves. You're probably actually not doing that badly. I think that, that DOP study is over an extended period of time, and it's not necessarily designed to clearly demonstrate that one country is doing better than another, although the UK happens to have looked worse. There could be a lot of things that are contributing to that. I mean, maybe you are actually asking your patients, which, there are many. I have a personal experience with a patient of mine who, for quite a while, just did not realise that his itch was anything to do with his kidney disease. And, he's a horrible story of his family segregating his clothes and washing them separately, and he was quite down about it. And so, if you're asking your patients, perhaps that means they're volunteering that more to these sort of surveys.
Liz, do you want to come in?
Only to say that having done a lot of reviewing of evidence of symptom prevalence across different countries, it is not even. So we're not even at the right starting place. So I think what you say, Brendan, is absolutely right. There's lots of factors that feed into why symptoms are either more prevalent or picked up better.
So Bliss has got a question for you, Jackie, about spray emollients, and that they're kind of much easier for older kind of arthritic patients to apply. So what are your thoughts on?
No, absolutely. I often have a debate with my patients in the clinic of they might be able to reach their arms or their hands, but they certainly can't put anything on their back or anything else. And anything you can think of to make life easier for them so they can actually, at least once a day, moisturize their skin. I think it really does make a huge difference. And yeah, that's a good idea. Spray emollients, they're easily available in the chemist or what have you. Good point.
And then Claire Douglas is kind of commenting on the pathway that you presented, suggesting that she would use mirtazapine before gabapentinoids because she found it's very well tolerated and very successful for itch. Now, I wonder what you thought of the pathway, Brendan. Would you kind of agree with kind of Jackie's pathway? Is that kind of how you would manage your patients?
I would. I think, but that doesn't mean that there's not valuable experience out there and people may do things a bit differently, particularly when the pathway. I actually found watching Jackie's talk that I agreed with basically with all of it, but that is all based on literature that has its flaws and problems, and the Claire's experience with mirtazapine is something that I think we really need to take notice of, but equally remember that there's only one randomized study done at a single center, and we need to be cautious, I think, in extrapolating too much from uncontrolled data. But it's that sort of experience that should make us think, yeah, let's go on, and Jackie, we can team up and do a study on mirtazapine.
I would just add there that it's important for people to use drugs that they're familiar with, that they're comfortable using. I'm used to using both, but I'm sure people are not that confident with using gabapentin at times because it's not without its side effects, particularly in the more elderly and more vulnerable patients. So it's using something that you know how to use. That's a perfectly valid reason for why there's different practices out there, I think.
So when you have used diphenhydramine, have you stopped other medication for itch? Or have you used these as a more refractory kind of agent, or would you go in kind of a bit earlier in that pathway?
That's a good question. I don't have an awful lot of diphenhydramine, can't even pronounce it, diphenhydramine use yet, but I haven't stopped anything else. My protocol at the moment is if something doesn't work, add something in, same as I would with hypertension. I wouldn't swap it for another drug. I would just presume the patient needed more. And no side effects as yet, which is encouraging, and yet to be convinced about the efficacy, but we need to give it some time.
That's really interesting. And that approach of sort of multi-target therapies, is that where you need to go with itch? Our own unit's experience with diphenhydramine, I think we've 12 or 13 patients on it at the moment, has been actually really quite positive.
Good.
We have tended to stop other agents. And we've had some quite traumatic responses to it. But then equally, sort of caution that if you look at the big New England Journal study, I think although they had a significant benefit over placebo, there was still 50% of people in that study who did not get the minimal clinically significant difference, also sort of did not really benefit substantially from the diphenhydramine. So it doesn't seem to treat everybody. Oh, Catherine, I think you're on mute.
We've got a question about mirtazapine. So do we think that mirtazapine works because of its histamine inhibition as well? And does that mean it's dose dependent?
There's a bit of controversy. Yeah. I saw there's one of my colleagues in Australia, he's quite antihistamines and sort of thinks that they don't have a role in CKD-associated pruritus. I'm not sure. I think there's some data to suggest maybe they might be helpful, but whether they're as good as the other agents we have, maybe not. I don't know.
One place where I have used antihistamines if people won't stop scratching, because it's the scratching of the skin that generates the histamine that makes things worse. So if patients are scratching and getting a secondary phenomenon, then I think antihistamines are useful, but I left them out of my talk because I think, strictly speaking, they don't work on the uremic pruritus part of it.
Barney, do you want to come in and ask your questions?
I'll come in quickly. We're going to run out of time on this webinar, and I feel like I've had the mic a lot. But I guess the question that I wanted to ask people is whether anyone's got experience of using the kappa opioid drugs in people with CKD and conservative kidney management. I know we don't have the trials yet, but they seem promising.
Oh, I mean, that's the trouble with diphenhydramine presently. The only experience we've had is one patient in the oral diphenhydramine, a randomized study, and look, we think he got placebo. I mean, so, I mean, like Jackie said, I'm sort of hopeful that they'll provide a lot of benefit, but no experience.
Thanks.
David?
I have one final question for each of you for me, and I think Barney's also interested in this. I was intrigued by both the comments about turmeric and primrose oil, as sort of slightly weird and left field things, and want to know if there is some evidence, and as Barney wanted to know, why is primrose oil something that's being used in Australia, and I hadn't even sort of thought about it in this country.
Yeah.
And what is the evidence behind turmeric and how are we doing it?
Well, I might just comment on, so I kind of love the fact that evening primrose oil really showed up as an Australian thing, which I think reflects how much of our practice in this area is shaped by the stories that we tell amongst our own little communities and how variations evolve. The theory behind evening primrose oil is that it's rich in gamma-linoleic acid, which is metabolized in a prostaglandin pathway and may produce some anti-inflammatory effects on leukotrienes. So there's some theory behind it. There's no evidence other than the anecdotal evidence. You know, I've got some patients who like it, but that doesn't mean a lot. I don't know about turmeric. Jackie might comment on that.
Yeah, so turmeric's getting more and more popular in this country, and a lot of patients are coming to clinic saying they take it over the counter. What is it? Well, it's got a compound in it called curcumin, which is an anti-inflammatory polyphenol. It has got one randomized controlled trial in CKD patients of 100 patients where it did show some benefit in terms of itch score, but there was a confounding in the study because the turmeric group were actually more inflamed as measured by CRP. So I'm not 100% convinced by the data, but perhaps promising. And it's certainly used in other conditions. MS springs to mind. I can't remember what else off the top of my head, but people are reading about turmeric in various publications, not all of them the New England Journal, but we'll see. It's getting more popular.
It's impressive dealing with all those questions so well, everybody. We've got just a minute left, and there was one question left, which I thought Fliss could come in and provide an answer to, and then I'll do a final wrap and say farewell to everyone. So please, Fliss.
Yeah, just a question about end of life when pruritus is very severe. I presume you're asking about the last day or two of life when I think sometimes because people can no longer take their oral medicines in the last few days, they often get a bit of a flare-up if they've had pruritus that's been managed before. And I think Claire Douglas, who's on the call, will agree with this. We would normally use the more standard sedative agents in that situation where somebody can't use any oral medicines and they're really in the last few days of life. So low dose of midazolam is probably as good as anything. They hardly ever need very much, actually. But it's more for the sedative effect because you just don't have time for other things to work.
Thank you, Fliss, for coming in and dealing with the last question. I hope my thank you slide has come up to everyone. Just really want to say thanks to Jackie and Brendan for bringing such incredible talks to give to everybody today, and to the audience for bringing their questions to them, which I thought they dealt with amazingly. There were lots of people involved on the panel and behind the show here, which I feel like I failed to introduce, but you've met some of us. Some of our names are on this slide, and just thanks to everyone for making this happen today, especially those people at the UK Kidney Association who do all the hard work organising it. And that leaves us with no time and nothing else to do. So thanks so much for coming, and goodbye.